All right, I think we'll get started. I'm Scott Podolsky. It's my pleasure to introduce Robert Riviello, Bethany Hedt-Gauthier, and Fredrick Kateera as a demonstration of the interdisciplinarity of the teams that are informed by our department and by PIH to confront existing global health challenges. Robert Riviello is a remarkably innovative surgeon and assistant professor of surgery and global health at HMS, a director of the global surgery programs at the Brigham Center for Global Surgery, Center for Surgery and Public Health. Bethany Hedt-Gauthier, who received her PhD in biostatistics here at Harvard, is likewise hailed for her innovation in trial design and interpretation, is associate professor of global health and social medicine at HMS, and associate professor of biostatistics at the Harvard Chan School of Public Health. Meanwhile, Fredrick Kateera has earned both his MD and his PhD as an epidemiologist, and is the chief medical officer and director of research at Partners in Health Rwanda, and a faculty member of the University of Global Health Equity in Rwanda. It's a very talented team and part of a larger team. We're speaking of today on Cesarean Deliveries at district hospitals, key lessons for optimizing access and outcomes in rural Rwanda. Thank you.
Thank you, Scott. We're going to do this in this order. So, who's speaking? Thank you all for coming. We've been introduced. This group of us, the three of us, started working together 5-ish years ago and came out of sort of a stepwise process of honestly getting to know each other in relationships and bit by bit coming up with ideas, but also learning to trust each other better and realize our value alignments and our goal alignments. And so I hope this reflects some of the intellectual work and the equity commitment and our commitment to equity, not primarily for patients, but also for our larger team, some of whom are represented here, some of whom may or may not be listening in, most of whom are not in this room or listening in, both US-based and in Rwanda. So, Cesarean Deliveries at district hospitals, key lessons for optimizing access and outcomes in rural Rwanda. So, 3 points to the outline, and it'll be me. Number one, I'm going to give a background on surgery globally and in Rwanda, and in Partners in Health specifically. Then Fred's going to talk about, going to do kind of the lion's share of this presentation, the key lessons from the work to date. And then Bethany is going to talk to us for the last 10 minutes about where we think this work is going forward. Can you hear me in the back? Mm-hmm. Hopefully people on the WebEx can hear me too. Okay. So the first step. Lancet Commission on Global Surgery, the 2030 report. People familiar with it, not familiar? So about a quarter. Okay. We gave a similar talk yesterday at Partners in Health, and I'd say about a sixth where we're. The Lancet Commission was one of these giant reports from the Lancet that had a lot of leadership come out of here. It came out in 2015, and it gave 5 key messages, 6 key indicators, and sort of a pathway forward. All I want to do in this slide is give you those 5 key messages to kind of get you a sense of where global surgery fits, perhaps, in a larger global health discussion. So, 5 messages. The first is, in a world of 7 billion people, 5 don't have the kind of access you would expect for yourself and your loved ones to essential surgical care. Timely, affordable, safe, quality. That doesn't mean you can do cardiac surgery if I need it right now. It also doesn't mean that 5 billion people need surgery now. 5 billion don't have access. 143 million. So in a world where it's about 320 million operations done per year, we kind of need to double that or increase that number 50% to get to an essential minimum. That number doesn't talk about equity though. So in the poorest third of the world gets 6% of the world's operations. So yes, we need to increase the number. We also have to rearrange the equity proposition for who is getting surgery in a timely fashion when they need it. If you're lucky enough to be one of those 320 million people who get the surgery you need when you need it, 1 in 4 of you are going to end up with catastrophic expenditures. We would also say impoverishing, except that most people who get surgery already are on the poverty line, so spending $1 on surgery is going to impoverish you. Catastrophic generally means things like you spent 40% of your income that's not sustenance. So after paying for food and housing, 40% of your income went into paying for surgery. That's direct and indirect costs. So it's super expensive for the individual. However, this number is, I can't really think of this number, 350, if we invested as a world, $350 billion. Joya Mukherjee yesterday pointed out that was a day of war in Iraq. That should lead to huge profits globally in the economy, to even more insane numbers, $12 trillion of money saved. The world's global economy is $70 trillion per year. To put that in context. Now, this is $12 trillion between now and 2030, so it's not that this surgical investment would increase the global economy that much, to 20% of it. But it's a massive return on investment if, as a global community, we did so. And the final message is a message that we got from Jim Kim, I'll just say the plug, who is having a reception tomorrow and giving a talk on Friday at Brigham, if you weren't aware, in his role as the WHO, that surgery and obstetrics and anesthesia, the surgery care delivery system, is part of health system strengthening. And so it is an indivisible, indispensable part of healthcare. You might say, well, but how many people actually have surgical problems? You said, Robert, that 5 billion people lack access but don't need it. About a third of the global burden of disease at some point in that process need care delivery. It turns out that most disease categories will need a surgical intervention. Doesn't mean that the whole thing is a surgical problem. Diabetes is not a surgical problem unless you need an amputation or a toe debridement or a bypass, in which case it is. So there's a lot of need to deliver care. It turns out there's a problem with the quality of care delivered in surgery. This paper is from The Lancet just 1 or 2 months ago. It's a modeling exercise, so it's, there's a lot of ways you could argue against it. What they looked at is, of all the different disease categories, where are people dying? And this disease category hadn't really been looked at, the red one, postoperative deaths. So perioperative mortality, which is one of the indicators that the Lancet Commission asked countries to start measuring. Bless you. 7% of the world's global disease burden are people dying. 7% of the world's disease burden of death is people dying after surgery. That's also a problem. So there's a quality piece here. A lot of those complications are surgical infections, which starts to lead us towards some more Rwanda-focused bit. So in Rwanda, just a flavor for surgery. So up in 2016, there were essentially no specialists in surgical care. So obstetricians, MD anesthesiologists, surgeons outside of the capital and the major teaching hospitals. There's a couple rare exceptions at missions hospitals. The Human Resources for Health program, HRH, many of you are aware of it, was this program of the Ministry of Health tying the University of Rwanda with a whole consortium of academic partners stateside, of which we here were a key one, to help upskill and increase the number of health providers, doctors, health managers, nurses, dentists, over a 7-year-long process. And I bring that up because in the surgical space, SAO is surgeon, obstetrician, and anesthesiologist, physician specialist. In the surgical space, one of the Lancet indicators, Paul, there's a seat for you right here if you like.
Oh, thank you. I was really looking very excused.
One of the Lancet Commission indicators they recommended was that measuring out the SEO density. How many surgeons, obstetricians, and anesthesiologists per 100,000 do you have, with a target of 20 per 100,000 to get to sort of an inflection point of where that actually makes population health. Rwanda started at 0.7, which is about typical for the area. And after, by 2023, the kind of the lifespan of the impact of the HRH program, well, I've gotten to 2.5, which is almost only a tenth of what the goal was, although for the EXA region, this is COSEX's, the College of Surgeons of Central Southern Africa, their goal, 5 per district hospital, 5 per 200,000. So, huge impact in that sense, except can also come with the ability to implement across staff-based systems in a commensurate way. And I think that was one of the challenges we need to go work on going forward. The last bit is, like most places, most of surgery in Rwanda happens at the district hospital by non-specialist teams with the general practitioner, non-physician nurse assist, and non-specialized perioperative nurses. And most of those operations are C-sections. That's true in our setting, in largely still true in Kirehe. Which brings us to IMB, Museum or Partners in Health in Rwanda. Many of you have seen this map. Those 3 stars is where Partners in Health supports district hospitals and where the focus of our efforts together has been. Those surgeons, obstetricians, et cetera, that have been disseminated around the country to provincial hospitals. So there is some dissemination since 2016 of specialists in the country. So getting to the actual research work. A lot of this relationship and collaboration started with IORTs, Intermediate Operational Research Training. That's not surgery operations, that is health systems operations, and understanding how our health systems work using routinely collected data in the health sector. In round 2, there began to be a surgical component to that asked a number of questions of how are we delivering surgical care at the PH-supported hospitals. A couple highlights. And by the way, all of these, the scholarship that came out of that are papers that have been co-first authored by two, in each of these, Rwandans, almost all of them, first-time authors from PH, from the Ministry of Health, from the University of Rwanda, through this mentoring program, which is really remarkable. So things we learned. 9% of neonates having substantial complications. That's an order of magnitude of what would be acceptable here. If you live far from the hospital, not a big surprise, but if you live far from the hospital, much worse neonatal outcomes, and then our research is showing the same for maternal outcomes. Of the non-obstetric surgical cases, 20% across all 3 hospitals were getting referred. A lot of these for orthopedic trauma at Kirehe District Hospital. If you took out Batara, which intermittently had some sort of more higher-level surgical capacity, which is about 1/3 of all surgical patients were getting referred. Imagine that myth of referral, that Paul's talked about in the past. That means central hospitals that are overrun and also not delivering care. I'm going to pause here like I did yesterday. Just a positive shout out to Bethany. So a couple weeks ago at CUG, Consortium of University School of Health Equity, for this work and others, Bethany was awarded the Belgi Award in Education, Excellence in Education Research. Rolling out this work then came a couple of NIH grants which got NIH funding. When I'm going to show you actually I'll talk to you about both of these on the next slide. So the first one was a mHealth grant. The next one we called a telemedicine grant. They kind of flow into each other. So the first one aimed to, can we figure out if we can support community health workers to identify surgical infections, surgical site infections earlier in the community, supported by an mHealth tool. So the first phase, we had about 500 patients who came back to the hospital, were seen by a GP as a gold standard, were seen by a community health worker with a tablet that ran them through a long battery of questions about surgical site infections. And can we make those match up? So the community health worker perform as well as the physician using this protocol, and we optimize that protocol from a series of 9 questions down to a 3 questions reproduced in the community. The second phase was then a 3-armed randomized control trial, and the randomization was about follow-up. The standard follow-up is moms after C-section delivery to come back to the hospital for a wound check. The next arm was send a community health worker with that tablet, with that battery of questions, and take a photo. The third arm was just call her.
It's not that.
So things we learned.
People sitting in there with your chip.
Hello, we're having a talk right here. Maybe you can mute it. So the things we learned, and then I've got to wrap up. So the things we learned are actually not necessarily what we expected to be. In that first arm, yes, that protocol, which is 9 questions, all the stuff that those who nurses and doctors learned, rubor, tumor, gallbladder, or other signs of infection, 3 of them really helps. Fever, purulent drainage, and pain at site, which are most indicative of having a surgical site infection should be returned to care. Oh, that was great, except that it turns out that the tool seemed to work a lot better in the hospital setting than it did at home. It has to do with coaching about how to use it with the community health workers. Second point, and these 2 are the second arm. So one really cool thing is that almost all of the moms actually got visits by community health workers empowered with the tablet and the mobile health device. We didn't know if that could be done. So 90% And we also learned that the phone, which you might think is, provides easier access to cheaper than many community health workers out there, didn't perform nearly as well. However, it turns out moms were coming to the health centers for follow-up quite regularly, which we didn't know. So that was a good finding to kind of give kudos to the primary care portion of Rwanda's public sector of health. It did mean that perhaps with a narrow view of community health workers going to homes to identify surgical site inspections wasn't a great buy because they're already coming back. So we sort of proved the null, which is not something you actually want to do with a randomized control trial. But then it led us into a whole other group of work, and so to that I'm going to pass up to Fred to continue.
Thank you. Thanks so much. I hope my voice is as loud as Robert's. Nice to talk to this group. My goal is not to distort you one day in the year when you have a meal together. Some of our work together. So I will speak a little bit about accessibility of C-sections and follow-up care. A little about infection and infection risks among these patients. We still have primarily followed up mothers who have had C-sections because in the 3 hospitals we work, this is pretty much the majority of the surgeries that we do. The desire was always to do a bit more surgical cases, but for different reasons, we are mainly doing C-sections. And then I'll speak a little bit about antibiotic stewardship programs that we're trying to study and some of the resistance profiles that we hope to understand. The credit for the cartoons is all Bethany. I did not intend to picture a mother in this way. So in terms of, let me just situate this in context. When a mother is pregnant, she would be expected in the Rwandan healthcare system to visit a health center. There are 4 of those visits right now. WHO is asking us to go to 8. I still have questions around who makes these policies, but even within the 4, almost about 62% of the mothers actually are able to go at least once. When you look at how many complete 4 of them, it's almost about 26%. However, in the Rwandan system, we also have a community healthcare worker component. So the mothers are actually followed up at home by these community health workers, but they will be expected to actually go to the health center. So when you go, when you basically have onset of labor, you would be expected to go to the health center. If you're deemed healthy enough and you're going to give birth by general delivery, then you give birth at health center. If there are concerns around that, then you can refer to a hospital. So that's pretty much the pathway that we looked at in this study. Now, we looked at costs and time associated with the pathway to care. Overall, it took about 30 minutes for a mother to travel from her home to the health center. And then from the health center to the hospital, it took about 45 minutes. This usually is an ambulance. There will be a call to the hospital to release an ambulance to come and pick a mother. But in between there, for different reasons, where ambulances are not available, either someone will get a car and hire it, or a bike, a motorbike, but by and large, usually there's an ambulance at hand to be called out, and then they come and pick the patient. But as you can imagine, if you have one district hospital, servicing maybe 15 to 25 health centers, there are always delays. So overall, for the population we followed, it took about 6.3 hours to actually travel from your home to the hospital, and it cost them about $4.5 US. Nationally, the amount of deliveries that are by C-sections are about 13%. In the eastern province, that is in both Kirehe, where this study was happening, but also in the neighboring district, Kayonza, where we also work, it's about 11%. As you can imagine, sometimes the C-section rates are a lot higher in the tertiary institutions, where you have far more capacities, and the kind of patients also visit tend to more likely select to have C-sections, but that's what we observed in this district. Clearly, we realized that long distances from health center to hospitals were associated with lower C-section rates. Of course, if you go into labor and it don't take you 6 hours to arrive at the hospital, it's not uncommon that along the way you give birth, whether at home or in the ambulance. But basically, you would probably be better off reaching the hospital in time to have a C-section and reduce any other complications. But we noticed that there were fewer, among the group we followed, the farther away you are, the less likely you're going to have a C-section. Of note though, health center hospital distances were associated with worse neonatal outcomes. So you may still give birth, but the outcomes amongst the children who are born to those mothers who are coming from distant places were generally much poorer compared to those who have traveled shorter distances. Vaginal birth after C-section is not generally done in most of Rwanda. Basically, the idea is, at least in many settings, then once you've had a C-section, you need to be tracked a bit more actively and intentionally, and probably be seen at hospital rather than at the health center. But because of the referral processes, mothers still go to health center to be seen, and then go to the hospital. That in itself is already a risk. You would almost think that we need to find better ways to circumvent that pathway and go directly to hospitals. But for other reasons of distance and affordability, but also we've noticed that usually the first-time mothers are more responsive to some of these kinds of care. The more children you have, the less likely you're going to follow what's recommended. But we found that 32% of the mothers who had the C-section, the only indication for that C-section was because they had one before, which speaks to, so we're trying to internally think of ways we can fast-track these mothers. Right now, in 2 of the districts where we are running a program around improving maternal and childbirth, in 2 of those districts, there were no maternal deaths actually the whole of last year. So that's now become the benchmark of public health concern, and the drive now is try and improve, number one, ultrasound screening for mothers to improve decision making for care workers, but also we are providing waiting areas. In other words, if you come from very far, you've had a previous car, or for some other reason you need a C-section, we are creating space for the mother to come and stay there for the last week before they give birth. So that when you go into labor, you just found the hospital. As you can imagine, most of the mothers who have had C-sections, they are almost expected to go back home around the 3rd or 4th day post-op. Part of it is just the feasibility of it. We have so many mothers giving birth, you need to give room for other mothers to occupy your bed. That shouldn't be a decision, but in this case, it speaks of how much more services we need in terms of bed capacity and all that. We also looked at C-sections and their effect on finances. I think Robert talked a little bit about catastrophic spending. Of the women who were in our study, 98% of them were classified as poor, and 92% of them as extremely poor. 93% had mitral. In Rwanda, we have a national subsidized insurance coverage for especially populations in the informal sector that tries to provide medical care at a much lower rate to increase access to care. In terms of those who had C-sections, the overall cost for each mother was about $56, 24 for the C-section and hospital care, about 21 on direct costs, and another 11 on indirect costs. Overall, 43% of these mothers ended up being in financial catastrophe. One example is 49% of them actually had to borrow money to have this C-section for different costs they needed. I'm not so sure whether this is relatable, even I can't relate to it, but you have been planning to give birth over the last 9 months, you know you're going to give birth, but you still have to borrow money, half of you, 1 out of every 2. Just speaks about the financial situation in most of the families on our side. 12 of them had to sell something in order to be able to afford to have the C-section. When we looked at day 10, postoperatively, followed up these mothers and asked them to actually come to the hospital for examination by the physicians, about 11% of them had a surgical site infection at their site. Actually, this put us a little bit in trouble. The director asked, no, the rates here are 3%. How come you're telling us it's 11%? What we noted is that their data was based on day 3 when they were going to be discharged. Our data was based on day 10, and clearly there were far more infections happening after they had been discharged. And because even if you had an infection, the first point of contact would be a health center, not a hospital, so the hospitals are not capturing these infections. But clearly the high cost of travel from home to health center significantly was associated with an increased infection rate. Of note, about 2% of these mothers end up having long delays, most likely because of delayed labor and all the complications that come into that, and spend a bit more time at the hospital. We looked at water and sanitation and hygiene. I think the concept here is, especially in Rwanda, when we talk about WASH and WASH programs, the significant majority, if not all of the funding, actually goes to improving WASH at household level in communities. And rightly so, there are big gaps to cover around WASH in households. But not many studies have actually been done around health facilities to make sure that there's enough WASH services. In this hospital, we actually looked at, this data is a bit summarized, but we even looked at WASH stations for the mother, WASH stations for the caregivers, but also for the medical personnel who are working in the hospital. And we found that there was a lot of variability around supplies and cleanliness by weekend or weekday. Surprisingly, there were far more supplies and cleanliness on weekends rather than weekdays. It almost feels like telling all mothers to give birth on the weekend. Water availability varied a lot by season. This particular district is plagued by a water supply system, and generally speaking, there's a lot more water available in the rainy season than the dry season. Of note, we noted that women who are hospitalized a day, if you came to hospital on a day when there was no running water, you had a much higher risk of developing a surgical site infection. I know that for many surgeons, I think the spirit of the message is that if you cut me well and cover me well, then I won't get an infection. But there are so many other things that actually influence risk of infection, and this particular study pointed this out. So what are we trying to do? One is this data was fed back to the hospital administration, and there's a lot of planning around infection control, how to address this challenge. For us, I think at IMB, one decision we made was to try and provide direct water supply from the main supply system of the district directly to the hospital. Because up to now, the supply to the hospital was coming through a bifurcated system, which meant if there was shortage, you would not get the water to the hospital. They had to drive trucks to pick the water. So we are literally investing in connecting the water directly to the main tank of the district that hopefully should give us continuous water supply. But even after that, this graph, pardon us for the colors involved, this was over a 2-month period when the study was happening. The deep blue looks at where there was no stored water. So in other words, in the dry season where there was no stored water, those are the number of days when there was no stored water in the 2 months. The light blue looks at not drinking water. And you can see how many days there was not drinking water in the 2-month period. The gray speaks of a time when there was no water flowing in the hospital. Interestingly, when we actually ask mothers, when we give you tablets to take, where do you get your water from? A few days there would be water given, mineral water, and bottled water, but there wasn't a station for mothers. When we talked about caregivers as well, there wasn't a station actually for mothers, for the caregivers. So, in other words, in my opinion, I think this is something that we need to spend a bit more time on in hospital designs, in planning for hospital services to make sure that all those people who are in hospital, not just patients, but caregivers, have access to WASH services. We went back to the mother's home. This is not an average home in Kirehe, but this is one of the pictures of the households that we went to visit. 86.4 of the households were reported using an improved water source. This data was collected using a WHO-validated tool around WASH services in households, and we found that even though 86% of them reported have improved water supply, most of them had to travel actually a distance to get that water. I do think we need to get some data around average distances to this. Of note, 13.5 of the households had latrines, and the only thing that was on those latrines were slabs, usually concrete slabs that are a bit movable where someone can stand. But we do note that clearly we need to, maybe not ask directly, but this data is going to be fed to the district leadership to try and see if we can increase coverage with toilet services in this district. Only 7.7% had washing stations with water and soap. Again, I think for me, this is one of those things. For most of us, the house you live in, when you walk out of a bathroom, there's actually a washing station. In real life, when you deal with populations where we work at, the toilet is a couple, maybe 200 meters, 100 meters away from the main house. It's not inside the main house. So asking them to actually construct a tap by the facility is practically not even feasible. So, but we did look at whether there was, even if it was a movable source, but something that's allocated for when someone walks out of the bathroom, where can they find soap, where can they find water? And we still need to invest a lot in that. So looking at the 11% infection rates, one of the questions we've had is, how is antibiotic stewardship? I think if there's anything I've learned, especially folks from this side of the phone, is the whole idea about, you know, every ill must be solved with a pill. So there's too much emphasis on antibiotics every day. Forgetting that in Europe, most of infection control was actually improved housing, improved drainage, water, but there we are. Antibiotics were one of the best discoveries, I think, in the 20th century. In the 21st century, resistance is probably one of the biggest problems we're going to have to fight. So what does WHO recommend? One pre-operative antibiotic within 1 hour prior to an incision. What we observed was 76% received a pre-op antibiotic. Of that population, that group, only 60% of those who received the pre-op actually got it within that 1 hour. So compliance is not happening as well as we thought it should be. In principle, WHO recommends that there should be no post-operative antibiotic unless there's a clear indication for risk of infection. In our population, 98% of those mothers got 2 full courses while in the hospital, and when they were discharged, they got another course of antibiotics. Now, I have worked actually in a rural hospital before, and I have practiced this as well. The idea is this: when I see you in the hospital, I have no idea whether I will ever see you again. So to cover all my bases, for every other thing that may lead you to have a risk of infection, I'll cover you with multiple antibiotics. But this is, unfortunately, number one, did not stop the infection rate. We still had 11% after all that cover. But also number two, we have to think about what is the resistance profile out of overuse of antibiotics. So we found no relationship between either having a pre-operative or post-operative antibiotic. My thinking is that since everyone was on a post-op antibiotic, you could not find a relationship. I guess we need to follow up a larger group for a long time to see whether this is still true. And then I'm going to call Bethany to continue this. Thank you.
Thanks very much. Okay, so just want to quickly end up with how this work is going to be moving forward, and then we'll open it up for questions. So I think first and foremost, our concern is around the antibiotic use and stewardship. And so we have several things underway and studies that we're planning on this. So there's currently a qualitative research study trying to understand why prescribers, why clinicians prescribe the way that they prescribe. We think that even if we come up with even if we agree the WHO recommendations are correct, or if we come up with what we think are the right recommendations for this context, unless we understand why prescribers are prescribing the way that they do and addressing that directly in the recommendations, it's not going to go very far. So we do have a body of work on trying to understand the reasons for prescribing. Fred is leading 2 studies looking at...
Fred is never leaving.
Leading 2 studies, one on looking at the prevalence of pathogens and resistance in wounds. So it's a point prevalence study that would be across the 3 district hospitals. And then the second is a point prevalence study looking at how antibiotics are prescribed across the 3 district hospitals to get a better sense, even beyond the C-section context, what are the prescribing practices and the risk of resistance. And then we're submitting a larger R01 grant, and our goal there is to both look at the carriage of bacteria that might already be resistant, the introduction of resistance through the course of prescribing antibiotics, and then trying to understand if these infections are being acquired at the hospital or home by doing some phylogenetic studies. We're really interested to determine where women are developing infections. The slide is a little bit shallow because I think this is where we're still brainstorming. I think there's such a long possible course of where these infections could be introduced, both from what is happening in the operating room to what's happening while the mother's hospitalized to what's happening in the home. And so we're trying to explore what are the appropriate methods for identifying where the infection risk lies. Certainly looking for ideas, anybody who has expertise or interest in studying WASH. And then I know Fred is championing a lot of WASH interventions that we hopefully will do some research around on the benefit of those interventions in terms of infection control. And then the third area that we're looking at is trying to identify what is the optimal follow-up for women. So Fred talked about how already the C-section is catastrophic, and that's a study led by Rachel, who I know is here, but Rachel, that's just looking at the cost up to the point where she's discharged. It's not looking at the cost after she's discharged and all the follow-up that's required. So Nicholas Rudolphson, who I'm also assuming is here somewhere, Nick is doing some modeling work. If you happen to be here at 9 tomorrow, Nick is going to be spending an hour presenting this mathematical model looking at if you look at the follow-up cost, it almost doubles the number of women who are experiencing catastrophic expenditures. If we can shift the way that we do follow-up from requiring the mother to travel back to the health center for wound care to utilizing the existing community health workers to do the follow-up, it becomes just a marginal increase in the percent that have catastrophic expenditures. And so I think we are interested in trying to identify ways that we can support the mother's healthy recovery in her own home versus requiring her to come back to the health center. So part of that is trying to see if we can identify and refer back problems in the home setting. So one of the concerns is if you shift to home-based follow-up, if there is an emergency, are we going to have worse outcomes for those particular mothers? And so part of it is identifying the infections. As Robert mentioned, what we realized, our simple screening protocol didn't perform well in the home setting, and so we have a new grant now that's looking at telemedicine. So in the grant that, as it was proposed, we would take an image of the surgical site infection, of the surgical wound. We would text that image to a general practitioner. She would send back a diagnosis, and then if it was suspected SSI, the community health worker would then encourage the mother to go back to the health center. We note that for 90% of mothers, they could continue to just get the care in their home, but for the 10% that needed the extra support, they would get referred back. So the research around this is, one, is it even feasible, the accuracy of those diagnoses on the text-based diagnoses versus a physical exam, and then doing interviews with patients and providers on whether or not they would trust this system as part of their clinical care. So we were really excited about this grant, and I was actually talking with Adeline in my office almost a year ago now, saying, I think the tripping point for this is going to be the cell network. You know, what if we take the photo, but the cell network's down, we can't get a diagnosis from the GP in real time? And she said, well, have you ever thought about just doing a locally run algorithm to do the diagnosis? And so that opened up a whole new body of inquiry where we actually are working with a team from MIT to do artificial intelligence to identify wound infections. So we had, from the first phase of the study that Robert talked about, we had collected 550 images, of which about 50 were surgical site infection positive and the others were negative. And we had just been sitting on this bank of images, not having any real intent of how we were going to use it. And at the same time met this gentleman from MIT who specializes in photo-based diagnoses. And so we've been working with him, and essentially he goes through, uses computer algorithms to go through the photo and extract three features: luminosity, which is basically contrast and brightness, redness in the photo, and blueness in the photo, and looks at mean and variation of that. And if you graph those traits on a 3D plane, it actually is, there's a clear planar cut. And so what we found just in this early artificial intelligence work is that we were 100% able to predict surgical site infection just based on the image itself. And so we're rolling through the device center, field testing of this work into our telemedicine study to see if what we observed in these original photos actually translates to effective diagnosis in the field. The other part of how we move forward is not just the work that we plan to do, but something that Robert mentioned, the intention of how we want to move the work forward. So we've been very committed. It's, I think, part of the reason why I so enjoy collaborating with Fred and Robert, that we want to use this as an opportunity to develop people across our partnership. You know, I think this is Partners in Health, Brigham and Women, and Harvard Medical School. It is, you know, an example of the partnership. And so this was our COI meeting that happened in December. And if you look, it really represents individuals from across multiple institutions who have been key for this work. And we just wrote up a piece about some of the lessons we learned about how to intentionally grow this space in a way that's collaborative and inclusive, that does what we think is the best research, but also supports the growth of our team. So I think we talk about it in the context of global surgery research, but I think it applies to other research programs. And we have several training components underway as part of building that partnership. So with that, I want to thank you all for coming. Fred, thank you for taking the time to be here this week and for presenting, and open it up for questions.
We can't all stand right here because whoever's watching will just stay back.
Your catastrophic expenditure data was determined by survey?
Behind you.
Yeah.
Okay.
It was all survey at the time of discharge.
Okay.
So I can imagine lots of other potential uses for AI-type data. And one of the ones I've been thinking about for a while is, there's apparently a tool out there which will, if a pregnant woman is using it, I don't know at what stage in pregnancy, but will pretty accurately predict the day of delivery. Seems to me that would be very beneficial for us, because instead of bringing them in for 2 weeks, we could bring them in for a day or 2 days. Have you thought about this at all? I think it raises two questions. So has that come up at all? But then it really comes to a much bigger question I know you can't really answer, but I'd love you to address, which is, how do we make sure that this move into AI is going to result in equitable products that can be used for global health gains and not only for the benefit of either the companies making them or the countries that already have them?
So I don't know that technology. I'd certainly be interested in it. I don't think Izzy Poulter is here, but Izzy Poulter was doing some work from Zanzibar, where effectively the biggest predictor in a woman failing to deliver in a health facility there was that her estimated due date was so far off. And so I think any technology, I'm looking at Annalena, probably have more to add on this than I do, but any technology that can help improve, even if it's just getting ultrasounds out to the district hospital or to the health centers when women come for antenatal care, would be huge in terms of all types of benefits, including this particular work. So I definitely would be interested to hear more. In terms of the AI, what I can say for our team, we're very conscious of who participates in the work and who owns the work across the board. And one of my biggest concerns is in the AI, because there's so few people who do AI, that you lose a bit of control over who's participating in that space. We do have one of our PhD students from Rwanda who's going to be working under Rich Fletcher to develop better skills in AI so that he can at least be a stronger advocate and participant in that. I don't know if you want to talk more generally about AI and ownership and the industry.
I mean, it's way out of my sphere of experience, but clearly it's also the future of diagnostics, so we have to be engaged, I believe. But maybe now is the best time as it catches up to start having some clarity on how do you engage with groups like MIT. I think MIT, maybe training institutions, because it's probably not a financially driven, for now anyway, it's more in the science development. Maybe if we developed a group and you can control the narrative from the very beginning and have some ground rules, that may make a difference. But against what we are losing by mothers not coming because of you can give birth either 2 weeks before or 2 weeks after, this is something that for me makes a lot of sense right now in terms of improving, promoting basically in-time referrals and making sure that you capture mothers and they plan well as well to come to the hospital. But I still don't know about the AI mic as well. I actually asked Bethany maybe we need to concoct a new name, because even just mentioning artificial intelligence in my setting sounds very weird. So maybe we need a new name that's not fancy, but a bit more.
Well, you have genuine intelligence.
Yeah,
I'm just, I know you all of you have hypotheses of one sort or another about, some of these questions you're asking, or hunches, and especially you have with the deepest experience. I just wanted to ask about the microbiology and drug resistance. Do we have any? It's not straightforward, and all the ID doctors know this, and the surgeons too. With these procedures at this time, I mean, in some wound infection, it's pretty straightforward, probably what the causative pathogens are likely to be. Not entirely, but it's a little bit different in this setting when you have women returning to places where they don't have perhaps a cement floor, and they, as you said, pointing out, wash stations, many of them do, et cetera. Just wondering, do we have any data at all that is not like swab data or things that we can't trust on what are the causative pathogens and what are the drugs to which they're resistant, right? Because that, the prevalence inside an institution or region, a district hospital vary even within a country as small as Rwanda or a county in the United States, for example. And the second thing is the antibiotics given pre or post for the reasoning that you mentioned, Fred, which, is a very compelling reason, right? Because you're going to lose these patients to follow-up in the sense of they're 6 hours away, then the community health workers aside, just for a minute, what are the pathogens, what's the drug resistance, and where do you think this is occurring? I mean, I know you're going to investigate this and be rigorous, but you can't pretend that this is far out of your realm of experience like AI. So.
Lisa, do you want to say something?
Oh, and there's one other thing. There's one other thing. What are the drugs that they're giving? Right? Because having practiced in all three of those hospitals, I've seen some pretty surprising variation, not only on timing, on whether or not protocols follow, on what the antibiotics are. Yeah. So some of them, are very unlikely to cover gram positives or with any modicum of resistance. So those are three different questions. You can skip the sociological one if you want, but I know you know.
Well, I'm telling you Lisa because she's doing work in Bara, which is not far from us and very comparable setting. For this study, the most prevalent use pre-op was ceftriaxone. I think almost 80-something% were ceftriaxone. And then a few people doubled that up with ampicillin, but generally it was ceftriaxone. For post-op, in the world was mainly ampicillin and gentamicin.
So, I mean, again, that's what I've seen as well. And, it's not, you can't find Vanco, you can't, the cefazolin is blah, blah, blah. I mean, it's not, if these are, wound infections from skin flora, those would, maybe this 11% or 10% figure is, I know, and again, I'd love to hear the hypothesis or what you're thinking.
I'll just mention briefly, so we've done some work in Uganda, sort of neighboring areas, and this is a couple years ago, but found very similar things to what you've all been discussing. And we did not do wound swabs because we were concerned that we would get a lot of non-causative pathogens that we would culture. So we didn't do that. I think that oftentimes the infections that start from within are polymicrobial. The ones that are strictly wound infections may be monomicrobial or a small community. And the thought is that there's more of a shift now towards skin flora, away from skin flora like Staph aureus towards gram-negative rods. And that sort of things I think Bethany really wants to look at in this future study, which is really a good idea. And part of that may be just what we're selecting for with these antibiotics. In our other study that we had done in Mbarara in Uganda, where we're looking primarily at other types of infection, bloodstream, urinary tract infection among women postpartum, we found a high proportion had resistant gram-negative rods. So they're getting so much antibiotic. In Mbarara, it's very similar regimens after delivery. It's usually ceftriaxone and flagyl for 3 days, and then they switch to some oral regimen before surgery. It's either ampicillin or cefazolin, and a lot of that's really just about ease of dosing. And postoperatively, one of the reasons they give antibiotics is to have women stay for their postoperative checks at day 3 so that they are getting what they perceive as care during that time. So there's all kinds of complex reasons that we've been discussing. But yeah, I think there is a lot of reason to be concerned about different pathogens we would see here, different pathogens, different places, and, sort of unusual antibiotic regimens based on whatever's in stock.
Liz, forgive me 1 second, but I mean, having been involved in some of these discussions, international discussions, here there's the Alliance for Prudent Use of Antibiotics, but I've seen a lot of public health figures say, well, the prudent use of antibiotics is don't use them at all, ever, for anything. And it's an outrageous kind of way to proceed, right? Is that you can't handle the antibiotics, you people. They're not talking about the moms, they're talking about the hapless 22-year-old nurses, right? So don't use them at all. And of course that doesn't work because then people just go to a market and buy them or get them some other way. And, that's why I'm asking the sociological questions, and I'm sure you guys were doing this, in Uganda as well. It's a completely unreasonable for any study of human behavior to think that that's going to work by just withholding. And we've seen that with chronic infections again and again. You were there for some of those discussions, Rob?
Yeah, no. And what I'd add to, or sort of filter in all this, is that it's not, the sociology isn't just at the district hospital, it is throughout the health system. Yeah. So University Teaching Hospital Kigali, a simple hernia repair gets the exact same demonstration of antibiotic prescription. Maybe 50% get 1 dose right beforehand as expected, and all of them will get a week afterwards for the same rationale. Oh, and we're putting a piece of prosthetic mesh in, and that might get infected. And you don't know what home they're going to if they have a dirt floor. I think also if you filter all the way down the pyramid, down to health center, and you look at health center registry, somebody comes in with a cough, well, it must be pneumonia, comes in with a fever, it must be malaria, comes in with diarrhea, it must be diarrheal illness. All those folks will get antibiotics, and if they don't, then they'll get them somewhere. So at CHUB, the University Teaching Hospital in Butare, a few years ago, remember you guys with that?
3 years ago.
Yeah, 3 years ago. So they look at patients coming in. 50% or so of patients coming in were coming with drug-resistant gram-negative colonization. And within their hospitalization, that would go up to 70%. Their caregivers, not the sick ones, their caregivers came in 40% colonization, and they would go up to 60% in the same period of time. So they're already coming in with MDR bugs on them. But there's a system-wide, it's sociological, and it's
political economy,
economy, all these things.
Yeah, maybe we need to go back to days when doctors used to write badly. They couldn't read that well. So the mother would go and say, I want chloroquinical or whatever. Some people have been arguing that part of the challenge is with all the open shops where you can easily walk in with no compliance rules. And of course, internet doesn't make things any easier. By the time a patient comes to you, they already know what they want from you. If you don't give it to them, at least in Africa where there's no compliance, they'll go and buy it. So there's a lot of overuse and abuse. So compliance, I think, for me, was a very big job. And in Rwanda, it sounds like something that can easily be done, by and large, around just strengthening antibiotic prescription, and you can only get an antibiotic when you have a prescription. We don't do it as well, but it's something that, if reinforced, can hopefully reduce overuse of antibiotics.
But also monitoring of the changing resistant patterns. Those are rapid changes. We see them again and again, institution after institution, setting after setting. United States, where we weren't using chloramphenicol, that was like a wonder drug 60 years later, because no one's using it because it causes anemia in 1 out of 36,000 whatever, and so then it was useful again. But that had, that monitoring, I don't know if that could be done in Mbarara, but even in Malawi, they were trying to do that for a while. Sorry, Liz, my apologies.
Please, then,
I'm just curious, given the evidence of the low level of wash during discharge, are women told what they should do or how they should take care of their cesarean wounds? Or in spite of?
Usually, in principle, the after a surgical incision, the dressing you have, you're really not meant to take it off. So the idea is...
But do they know that?
They are told by the nurses. But in principle, over the years, the material that's used falls off by itself. It's not that adhesive enough. So once it falls off, then you sort of have to pay. So, you know, it's a lot harder to cover it again. And now they're in their rural settings, they can't just quickly come back to get another one. So we've been trying to think of maybe work around that as well, to see whether we can either bring in a product that is adhesive enough for that long period and see whether there's a difference between that and what is now being used in terms of infection control. But it's sort of a murky area right now.
We did have a data point for that. I want to say it's like 20% of women, by day 10, their gauze had fallen off and were quite dirty and contaminated. We also have a qualitative study that we didn't present here that talked to women who were in our standard of care arm about what were their pathways, how did they care for themselves and their wound after. And one of the things that's coming out of that is they felt like they were getting very conflicting instructions at discharge from different healthcare providers. And so they're not quite sure what they should be doing.
Which is my follow-up question. Are there any systematic approaches to discharge, and Bethany knows why I'm asking this, in Rwanda with regards to what a woman should be told after C-section in Rwanda?
Can I ask, Kristen, do you have something to say? She was the district director of clinical services once.
I'm sure you get the next question.
Less than 1 year ago.
Variable, it depends on who's doing that C-section and who's the nurse that sees you before you discharge from. So it's not that it's not a rule that if before discharge you need to go through this points. You need to explain clearly how to take care of the wound and then remind what are the signs of infection. So it depends on where you have your C-section and who are the providers, which I think should be made clear. And if we have also maybe something to remind the providers, if the discharge day, remember to go these 3 points, and that could also be helpful. And my question was, I haven't looked at the protocols, the C-section protocols in a while, but I remember when I was in medical school, and I just turned 10 years after treating it. I'm too old. We were trained on giving antibiotics after on the discharge day. So did that change, or it may still be somewhere in our protocols? And that may be one reason that GPs are still prescribing. If that's the case, maybe we need to go back and then from medical school and also to the Ministry of Health protocols to make clear that that doesn't happen there anymore.
I mean, when the study was happening, there were no protocols that were either printed or hung up on the wall, against which you could support compliance. So maybe in the training it happens, but remember, especially in Rwanda, doctors...
Yeah, but for accreditation, we should have something.
They should be, yeah. But when we were doing the study, they were not available. And I think one of the recommendations was try and understand why people have different preferences and on what basis they were prescribing the antibiotics. That's part of the study that we're going to be doing. But I completely agree that having protocols and ensuring there's a compliance process, again, to enforce those same protocols will be helpful.
When I'm looking at the clinical folks that we collaborate with, my opinion is, from what I can tell, the WHO protocols were not developed with Kirehe District Hospital in mind, right? Like, did anyone go in and say, what are the pathogens that are causing the infections? Where are those infections happening? And so when we talk about the disconnect between what the WHO is recommending and what providers do, I don't think that the WHO recommendations should be our gold standard, per se. I'm not necessarily saying what the GPs do should be the gold standard either, but I definitely think we need some data to start informing how we prescribe.
And one of them is day 10, go back for postnatal. I mean, after C-section, you live a couple of kilometers away, expected to come with your baby day 10 old. It's practically not possible. So we need to, again, I think these are spaces that we need to explore around how to optimize patient care, but also in view of patient behaviors and possibilities in terms of taking healthcare services. I think there's a lot of room to understand that better.
I have a question. First of all, I just want to congratulate you all on this work. I think it's such a great example of collaborative work and has produced really interesting findings that have direct implication for the women in the study. So thank you all for providing that example for us. My question is around this, or comment question of follow-up, and where the follow-up for the wound fits into the follow-up for the woman-baby dyad in general, and how many times they're meeting with the health system, because I think it's easy to get focused on the wound, but there might be other benefits for the woman coming to the health center in post-op day 10 with her baby, perhaps, that are beyond surgical site infection that we might lose by doing a home-based collection. And even here in the U.S., there's now a push to have more contact with women postpartum rather than less for a myriad of different reasons. So I'm curious if there are other reasons that they might need to go back, including potentially even just removing the sutures, because I think they use a lot of permanent sutures that need to be removed.
So much now, not anymore. I'm also looking at Jean. One of the things we've been talking with Jean, but mainly from the NCD space, is how things like a well-woman clinic that is truly integrated around patient needs, not around clinician observation. We keep saying things are integrated, but what we are actually saying is that there are 12 programs in the hospital that we have set up, but they are all almost by and large vertical. So if a mother comes for vaccination or immunization for that case, all they get is vaccination and then they go back home. So they never get to know what other services are available, and those services are not organized to the convenience of the mother. So one of the things we're trying to think about is maybe a well-woman clinic, so that even if you brought your child for vaccination, that's the primary reason you came, you're also taken through a checklist of 7 other things that you should benefit from at that time. You can opt out, but at least you get to know about them. And then should you choose something, it's optimized for a short stay at hospital. You also don't have one line seeking vaccination, another line seeking, because we have all these services by and large, but the way they are set up, of course there are other reasons like just staffing levels and all that, but we think that a model integrated truly around patient needs and what's available may make a big difference, if for no other reason, just for the mother's experience when they are there. Because we think one of the reasons why people don't come for medical services is because apart from not getting a very good service, they are also not, the services are not arranged around their interest and what is optimal in their care interest. So that's what we're trying to think about. A well-woman clinic will run around some ideas around names, but in principle we want to see if we can pair the mother and the child so that it's a mother-baby sort of pair interaction. I think personally that it may improve patient experiences and therefore promote people really coming to seek services in health centers. Right now, as it is, like in many African countries, you only go to hospital when you're sick, and when you've exhausted all your options. We need to take away that. I think people need to go to hospital, not just get what they came for, but also be introduced to all the other services available, and be done in such a way that it's optimized for that, for making sure you're not late, you're well attended to, you're well catered for.
There's nice plants and trees.
I think the only other part I would add to that is, in Rwanda, there are existing community health workers specifically for moms and their babies, right? So, ASMC mothers, prenatal, they see the moms postpartum. It's just that they don't do C-section follow-up. So for the 87% of women who have vaginal delivery, they get followed, I think it's like day 3, day 2, 5, and 7, they get visits at home by the community health worker. They may then have like another visit with the baby at the health center. We're just trying to align, can we align the C-section follow-up to what women who deliver vaginally do in a way that's safe, but then also financially more affordable. And then just, again, I keep coming back to these women have to travel so far postpartum and post-operative. Is it a way to ease some of that physical burden on the patients as well? But I agree that when the health center contact happens, it needs to be done in a way that's taking care of the mother and baby together, including the C-section care that needs to happen.
Just like a follow-up, so those comments were about, to your question of care delivery and operational piece of it. Following from the collaborative and interdisciplinary thinking part of it, I have to admit that yesterday was the first time I actually thought about this question. I've been coming to all these questions as a surgeon and say, okay, well, we'll do C-sections because 80% are C-sections, but all the other surgeries that I'm really interested in too. And it was yesterday that was the first time I thought, oh, what about the baby? The value of this interdisciplinary discussion is critical. And I stand before you humbled.
And there's also these, the interventions around the psychological well-being, the parenting, the idea of having a baby, much less walking with a wound, is terrifying to us guys, okay? But we have, even in this room and in this network, people who are studying, psychosocial, whatever the term may be, interventions, and looking at data that, shows that as you're saying, every trip to a center or a hospital ought to be, have the convenience, but the integrated. I mean, this is why Gene's bringing up, integration science. It's not pedestrian at all. I mean, we have a suite of proven interventions that, decrease depression, maternal depression, even. Right? I mean, I'm not saying it happens in a visit, but and surely most of that would conveniently take care of at home. But it's just so reassuring to hear you speak so forcefully about it. Don't forget the flowers, gardens, scented, smelling the trees.
I think if there's anyone doing work around the science of integration, I think personally that's something people need to think about more and more. I think of when I go to the supermarket, even if I'm going to buy an apple, the arrangement of everything is so that I also get to see everything else. But we don't do that in medical practice, and I think it should be done. Maybe we should. Yeah.
There's one more comment out there. I think we're actually not.
Quick question. What is the clinical course of these infections? I mean, how many of them do you just open the skin and it heals in 10 days and no harm, no foul? And how many of them go on to intra-abdominal abscesses and septic and die and all those things? Because those are very different pathological mechanisms.
There were no maternal deaths in two of the districts.
We didn't go that far. All we did is just on day 10, who had an infection and who didn't have. And that was decided by the hospital clinician when they returned. We did not sort of follow up their understand those things. But I do think that is something worth thinking about.
Because that would steer you toward different mechanisms of prevention.
Yeah.
One's an inside pathology and one's an outside pathology.
So within the study, everything we picked up was by day 10, superficial surgical site infection, open up the wound and drain it and pack everything.
Okay.
I think none of those 50 got referred on, which is what would happen if anybody's got a deep wound infection, either a deep surgical site infection that requires debridement or organ space that requires drainage. I'll stand back from non-study but health system perspective, working at the teaching hospital, which is where the bottom or top end of the food chain, depending on how you look at it. And there's a whole ward. And in maternity, within the maternity block, there's a whole ward for women who have devastating deep and organ space surgical site infections after C-section. And I presume that's true in Burrard, and I presume it's true in sort of large public referral hospitals around the continent, such that there's a perspective, which Kenneth was here, I was with last week, there's a perspective at SASCA that, oh my gosh, they're doing terrible work out of district hospitals. Look at all these patients at the OSH, at the outside hospital. Of course, it's a small percentage that come, and they come there, but it's devastating. And they're there for weeks and months in the middle of fistulas, and there is maternal death in that. Our study wasn't empowered to look at that, but it's there. You just don't know how much.
Well, again, this is back to this hostile attitude from various sectors. That obviously the majority of surgeries would have to be done at district hospitals because they're already traveling grotesque distances, and Rwanda is one of the smallest and most compact countries. Try to imagine Ethiopia, but the hostility is like you can't do these without a 10% infection rate, so don't do them at all. And we've heard that a lot, and even among allies at the Lancet and in the surgical commissions, you can't do it, and it for me a little PTSD part is like you can't treat AIDS, you can't treat TB. Not said to me. I'm saying they're saying that to a whole country or a region. And this kind of Luddite approach. If you have no electricity and no hospitals, then the cesarean rate in the immediate region could be 0, right? So, you guys and gals have to just be careful that you don't, let that interpretation of the default in some frankly public health and health and development circles, not clinical clinicians, to say this can't be done at all. No, I'm not like if we did a sociology, so you don't hear it as much in a mission hospital as in a of course the deaths are just being moved out, so you can't see them. They're being referred to die in a referral hospital. That's one thing. But if these, as that I took to be the spirit of your question, if these are not lethal infections that are clear up with debridement and are not peritoneal complications, then some sort of tinkering and systems improvement that you're proposing is the right way to go.
And did you A have a comment to Scott and B?
It was just a follow-up to that comment about the management. So it sounds like it is for the most part opening and debridement, because assuming that they've been on antibiotics already, not changing the antibiotics that they're on, or
they've run out of options.
They've run out of options, but then opening. And I think that has implications in terms of thinking about how this affects women and the expenditure, because now you have an open wound for a much longer period of time. That's more days lost from work and taking care of your family. So just people who are thinking about the economic impact of surgical site infection should consider that as well.
Great point. Your point is with somewhere along the way there was thought even within this, can we, you saw the figures on it represented $56 of direct and indirect costs for having developed a C-section, which by the way is about month's wages for women in the region. What is the economic cost for having developed a surgical site infection?
Or even just having a C-section in general.
Right. For those that have the complication, that piece we didn't work out.
By the way, the term, the myth of referral, I didn't make that
you
up.
got it out of chapter.
I got it out of a surgical.
Oh, you got it out of primary surgery.
Yeah, so,
For 1992.
Who knew that? Who knew that surgeons could write?
Yeah.